fungal susceptibility testing, drug monitoring, management of fungal infections, and research. She received her PhD in medical sciences from the University of Nijmegen, Department of Microbiology, Mycology section of the University Medical Center St. Radboud in the Netherlands. She participates in numerous national and international scientific societies in mycology and as a presenter and speaker. She was involved for several years in the International Medical Mycology course held in the Netherlands and also in Germany, Austria, Brazil, China. In addition, she has published numerous mycology journals and has served as a contributing editor to the Manual of Clinical Microbiology, in addition to the Atlas of Clinical Fungi. Dr. Vitale is coming to us straight from the FDLC Atlas course in clinical fungi held last week at Mayo Clinic, Rochester. The Jacksonville Area Microbiology Society is especially honored to host Dr. Vitale for a presentation on emerging and common mycosis in South America. Put it wherever you'd like.
Yeah, okay. Okay. So, thank you very much for your nice presentation. Do you hear me? Yes? Okay. I forget one thing, that is my glasses. Without glasses, I cannot do too much. You can imagine, that was when I was younger, but now, you know. So my talk will be focused on uncommon or mycoses that are more presented in South America. But first, I would like to thank Dr. Hadda, Dr. Valencia Shelton, Diana Mesa, and the Jacksonville Microbiology Society for this invitation. So for me also it's an honor to be with you and to share the experience that I get during this time, so we can share from me and from you. We can all together make maybe some interactive, and we can really share our knowledge, okay? So my objectives, I was thinking that was to try to show you what are neglected fungal infections, because there are many that are really on the side of the knowledge or are not really thinking of. So then another message that I would like to tell you is that suspicion is very important, because we cannot really suspect what we don't know. So I think a suspicion is something to take into account. And also then I will show you some differential diagnosis, because some fungal infections have clinical presentation that mimics other diseases that might be not related to fungus. So I have nothing to disclosure. So I thought to start in the other way, just to show you brief. One clinical case, as you can see here, the patient, let me put my glasses first. So this was a patient. Please hang up if you don't hear. I don't want that you miss anything. So the patient has 66 years old. This is a work published by Gomper et al. In 2016. He was originally from Brazil, from Minas Gerais, Brazil, and he consulted for this lesion that was erythematous lesion, as you can see there, that was on his left arm at the last around 2 years of evolution. So he has not another history of any other disease except that he took medication for cardiology reasons. So the first thinking is, what are we going to do if we have a patient like this, or is this patient have, and so what kind of samples that we are expected to have in the lab, or what we can advise even, because sometimes we could advise. I don't know here, but I mean, this is something that we can also do to advise what kind of samples can be obtaining to send to the lab. If you have any idea of something, you just tell me, so then we can do it interactive. So moving on, a biopsy was taken from this patient and was sent to the lab. And in the direct microscopic examination, it was, and in the histology, there were not evidence of fungal elements. So what is this? By the, sorry, because my hair is too long. Now. So, direct microscopic examination, nothing, yeah? But when it was seen on the culture media, it was seen after 5 days around growing of a white colony. And after 10 days, it turned into pigmented colony, brown colony. So in the microscopic examination from the colony, it was seen this highlighting hyphae septated with conidia that were brown, as you can see here, and it was disposed in sympodial conidiogenesis. You know what sympodial conidiogenesis is? It doesn't matter. No, the point is that from conidiogenesis means how the conidia grows. And there are different kinds of, so then you can more or less identify the fungi, at least at a general level, yes? But this is what it was seen in the microscope. Any idea? No. So finally, it was identified as Sporotrix globosa. And this identification was by molecular tools, yes? So maybe we can think in and until genera species. But for this Sporotrix, we need to do molecular identification to get the correct species. So for the treatment, itraconazole was given for this patient at a dose of 200 milligrams per day for 6 months, and not improvement was seen. So then it was given potassium iodide in 1 gram, and then it was raised up weekly until 4 grams per day. And finally, after 6 months in total of this treatment, improvement was observed. So finally, this was a case of sporotrichosis resistant to itraconazole. Yeah. Then, now I'm going to show you something related about sporotrichosis. I know that you have some cases here, but as you may know, the disease was common seen before in farmers, and it was related to implantation by traumatic inoculation from the soil or from plants. So it was considered a worker disease. And normally, the species that were involved in this disease was related to Sporotrichschenkia, yeah? So after, in 2001, around, starting a breakthrough in Rio de Janeiro in Brazil, and they were seeing a lot of sporotrichosis that attacks around more than 100 patients that, and in this case, the link were with cats. After, as you can see here in, oh, I'm sorry. So as you can see here, during years, the patients suffering from sporotrichosis were increasing, more than 500 with lymphocutaneous form. We are going to see later on the different clinical forms. In the end of 2008, it was seen that transmission of this fungus was through cats, by a scratch from the cats, or by sneezing, or even by feces that were into the environment. So then it was a kind of circle. With this scenario, in 2020, they have, because this was in Brazil, it's located in Brazil, started in Rio de Janeiro, in the streets, where the cats are everywhere. So they can really not control this disease. So after this, the new species related to this cat transmission, sporotrichosis, were identified as Sporotrix brasiliensis. So, and it's considered a zoonotic disease because it's transmitted from animal to human. So cats to humans, cats to cats, cats to dogs. But to humans is cat to human. Not cases the transmission from dogs to humans. So Sporotrix brasiliensis is a bit different as the others. I don't know if you know that Sporotrix as a genera is a dimorphic fungi. You know what that means, dimorphic fungi. Dimorphic means they have two faces. So in the environment, it is more in the saprophytic form, that is hyaline hyphae, or not hyaline, but they are in the phase of hyphae. And when you get the host turned into yeast, yes? So this is more or less what dimorphic fungi is, that we can mimic the situation in the lab, culturing at 37 and at 28 degrees, yes? So what is happening? For example, for Sporotrichentia, to say one species, when the person gets the infection by traumatic inoculation, then the host has to change from hyphae to yeast, okay? But in the case of Sporotrix brasiliensis, the yeast is already in the cat, yes, in the nails or in the claws, and even it forms biofilms. That means that the transmission is even easier from the animal to the host. It's okay? Yes? So the disease, as I told you before, was more seen in Brazil. Mainly the cases were reported there, but it's already in expansion because cases were described in Mexico, here, or even in the north of Argentina as well. Cats also suffer from the disease, and the point is that yes?
Does the cat show any symptoms of illness?
Yes, this is what I was going to tell you. There are two things. Sometimes the cats have not any symptoms and can transmit again. So you don't see any lesion in the cat. But can be transmitted by sneezes, for example, or as I said before, because it's maybe colonized on the nails. So maybe it's not. But the cat also suffer from sporodicosis. And they have in the face or everywhere in the body, so they can have like a human, the same disease. But in cats, when you see, I told you that we will see later on, for the diagnosis, it's a bit, some things are a bit different. So cats and humans have the disease, but sometimes can be transmitted even without evidence of lesion. Is that understood? Okay. Well, the clinical forms that we can see in humans are the fixed form, that is this when it's inoculated. So you have a kind of chancre there, and it's not expansion. So it's fixed, it's there. This is one form. The other is also inoculation, but then it's spreading through the lymph and heating. That is the form, lymphocutaneous form. So from the inoculation is transmitted like a nodules through the lymphatic. Then we have pulmonary involvement. So also you can have different CT scan from the lungs. If you see, there are different patterns there. And the signs or symptoms can be related with cough, dyspnea, shortness of breath, etc. And disseminated sporodicosis have also been described and were related most with immunocompromised patients, different kinds, HIV or lupus under corticosteroid therapy, or leukemic patients. So then involvement of different parts of the body can be seen, like in joints, in eyes, or even in central nervous system. Also, sporodicosis can be seen. So how do we do the diagnosis then? So the gold standard is still the culture of the fungus from the different specimens. The specimens can be any of these: tissue biopsy, CSF, blood, any of the specimens. Cultures, then we can obtain it by seed the sample in Saburo or BHA also, and the incubation is 5 to 10 days, as I told you before. But it could last maybe 1 month to become positive. So normally we leave all cultures in mycology for 1 month at least. In the microscopy, we can see yeasts that are round or cigar shape. And this is the yeast form, yes. Or in the filamentous phase, as I explained before, the conidiophore with conivia in symphodia. Symphodia means that you have one conivia, and then after the other is born, the other, so like a flower, let's say somehow. I don't know, okay. So in histology, the tissue reaction normally can be chronic granulomatous diffuse or granuloma or others. Also, the fungi can appear rounded, as you can see here, that can be confused with, with what? For example, this is, if you see it like this, you can think that it's maybe histoplasma, for example. So it can be confused. You have here giant cells. That is the reaction, the tissue reaction, a splendoric Hoepli phenomenon that is not distinguished only for this disease, also for others. And then the yeast that are really, really small. So the direct microscopic examination and histology is not really very sensitive. It's difficult that we can see all these structures, the east face from the specimen, from humans. For the cats are different because they have higher burden. So then the sensitivity is high. So you can see more easily directly the yeast from the cat. So then the diagnosis in this way is a bit more easy. Well, there is some pilot study with, so maybe I didn't know that you were going to be here. So this was a pilot study performed in Brazil, in which the 300 serum were tested, handed from patients that were suffering from cat transmission sporotrichosis. This is what it means, CTS. Also from other patients that have other fungal infections, and also from volunteers. So in this pilot study, there were found that the sensitivity was between 86 to 81%, and the sensitivity increased with the days because they are looking for antibodies. So after 20 days, then the sensitivity is a bit higher. The specificity was 82% in this study. The negative predictive value was pretty high, 90%, and the positive predictive value was 69 around. So there were some positive, false positive results that were cross-reaction with other fungal infections. This is always happening with the fungal infections. You always have a cross-reaction, as happened, for example, with galactomannan. Also, there are cross-reaction looking for aspergillus, but then it reacts cross-reactivity with histoplasma, for example. So there are normally these kind of situations. False negative results mainly were seen in the fixed forms, because it's fixed, it's there, so sometimes it's not, antibodies are not produced in a high amount. So this pilot study is a promising tool for further diagnosis. So other tests involved were immunodiffusion, for example, latex agglutination, but are not available everywhere. ELISA or Western blot were validated, but not commercially available. PCR also are in-house, so kits for this disease are also not available. The thing that is to mention is that the sequence using the calmodulin gene can distinguish between species, because you see that they are completely different. Sporotrix schenki do something different than Sporotrix brasiliensis, and some, or Sporotrix globosa and other. So they are species that are different. They are not a complex species because they are molecular different. I'm not going to talk about this, but just to let you know that you can distinguish between species. The susceptibility test in vitro varies between the species. So these are the most three frequent patients. So for Sporotrix brasiliensis, itraconazole, posaconazole, or even terbinafine are active. So those that are green are the most active, and those that are in red are the less active, and intermediate, the yellow ones. So in general, you see that echinocandins are not active in general, for example, and others like posaconazole or itraconazole or even terbinafine are the more active drugs. Yes? So for the treatment, is a recommended treatment. Itraconazole is the drug that is more given, and even plus due to the emergence of this species, Sporotrix brasiliensis. But potassium iodide is also given, despite have some adverse effects, but it's also given because low cost and is efficacious. The efficacy was a bit was good, and you have to think also that when these diseases are in low-income countries, so we need also try to find a solution in with other drugs that are less expensive. So itraconazole and terbinafine are the two most used for this disease. Amphotericin B can also be used when we have these disseminated infections, and then when it's progressing better, can be switched for other drugs like itraconazole. Then cryosurgery or local hyperthermia can also be coadjuvants to help in the treatment, and even more in pregnant women. Okay. Now, to finish this disease, I like always to show differential diagnosis, because you have, I listed just some, there are others also. For example, cutaneous leishmaniasis, that we have there a lot, pyoderma, cat scratch disease, so there are different ones. But it's better if I show you pictures, because, for example, here we have one lesion, as I showed you, of sporotrichosis. This is a fixed one, but if you see this, compared with this, it's almost similar as in something else, chromoblastomycosis. If you see this, maybe it's not really the same, but if you take out the crust, it could be that the lesions have this appearance. And this is something else, it's pyoderma or cat scratch disease also. Or in this lymphangitic form that I showed before, also, for example, cutaneous nodocardiosis can have this picture. So always we have to think about differential diagnosis. So moving to the case number 2, this was a woman. This was it coming to our hospital, was a woman with this lesion in her hand. As you can see here, she was a farmer coming from the north of Argentina. The lesion at the beginning was very small, but then it was growing. She went under different kind of treatment and nothing worked. So finally, they will decide to travel to Buenos Aires, and then it was going to our hospital. And it was 2 years duration with nothing, not improvement. And so with this situation, again, what can we do? So what it was done was to take the biopsy. You know that for biopsy, you have to separate in saline for the microbiology lab or mycology lab, and in formalin for histology, yes? And biopsy was taken in this case, but also a scratch from the lesions could be also helpful and even more rapid. So what was seen from the direct examination were these structures. Any of you, except Diana, know what this is? the structure. I'm asking about the structure. So the structures are, they are kind of cells that have septated in different ways and are called muriform cells. Yes, you know that the muriform cells are really related with a specific disease. So after the time, it grows a pigmented colony. And then from this colony, the microscopic examination showed the pigmented hyphae septated with catenulated conidia. And then we thought, of course, that we were in front of Fonsecaia, Fonsecaia species. We cannot say which one it was. So then I sent it to Westerbeek, to the Netherlands, and they found that this was Fonsecaia monophora. So this was a case, of course, of chromoblastomycosis. What I wanted to point it out about this, it was that Fonsecaia monophora is neurotropic fungi. So always the most common that we have in Argentina was Fonsecaia pedrosoid that caused chromoblastomycosis. So now we know that we have also Fonsecaia monophora that is neurotropic, and it was discussed. It was reported to have neurological diseases, pheohyphomycosis in other countries like China, etc. So the treatment was itraconazole because it works okay. Black fungi normally don't need treatments that are really difficult. The problem is that sometimes the outcomes are not very easy. These are diseases not very easy to manage, but the drugs act pretty okay. So itraconazole was given. We do drug monitoring levels for itraconazole or for posaconazole, voriconazole. We always do that. And it was first below the range. So we have to adjust it. Then it was high. So it was a bit tricky to manage this patient, but after it was inside the range, and the evolution after more than 2 months, it was okay with this patient. So the follow-up was when she came and after treatment, the result. Yeah. So this was reported as the first case that produced chromoblastomycosis due to Fonsecaia monophora in Argentina. So chromoblastomycosis then, what is a disease that is also implantation disease. That means that is acquired by traumatic inoculation from the soil, from the environment itself, spines or any other plants also. The infections were recognized by the World Health Organization as a neglected disease in 2017. Where is chromoblastomycosis? America is most in Brazil again. So Brazil has a lot of fungal infections, and even more in the region of Amazon, yes. For us, it's more in the north. It's because the climate also. So we have more in the north of Argentina. We never have a case from Patagonia, for example, that is in the south, okay? But also some other countries like Mexico, Venezuela, they were reported. In Asia also, in Madagascar, there were plenty of cases reported also from there. And the members that produce this disease belongs to this family, well, to this group, not family, Chaetotyriales, with all these fungi involved, Fonsecaia, Cladophyalophora, Phyllophora, Rhinocladiella, etc. The clinical presentation varies. Could be nodular lesions, could be cauliflower tumors, as you can see here, or you can have flat scaly plaques, as you see also here, or Here also, cicatrizal can be also in skin lesions that is spreading at the center. And the dissemination is by scratching, auto dissemination. It's not person to person, but just from scratching. And the problem with this disease, you know what it is, that is starting maybe with small lesions. But then, because normally people are, in places that are difficult to travel or to get or to centers in which they can be diagnosed, so then it can last maybe years and years. And I can tell you that we had a case, but this was time ago, with a person that will have 20 years of evolution. Can you believe that? 20 years. And the attack was like a cauliflower, like this, and it was the whole leg until here, from the feet until here, like a boot. Was something unbelievable. And you say, how is possible that you don't realize that you have this when starting? But that happened because people say, well, it's nothing, or no, you don't know, and they cannot travel. So it's unbelievable, but happens. So, and just 2 words about this, CAR9 implications. In this context, you know that CAR1 plays an important role in the immunity, yes? So, when some fungal or some strange body, let's say antigen, enter into the body, so there is activation, as you may know, of interleukins, yes? So then the immunological response take place, and when there are mutations in this CAR9, then the immunity is deficient. So neutrophils cannot really attack, macrophages also cannot really attack. So then the immunity is weak. And so why I bring this information, just 2 words, because chromoblastomycosis, for example, was thinking that occurs only in otherwise healthy patients, yes? And in fact, now, but not now, but from some years ago, it was seen that there are some spots, mutations in some spots in the genes that are implicated and related to suffering of chromoblastomycosis that was described later, but previously it was described, for example, mucocutaneous candidiasis. That also that patient have problems in mutations in the CAR9 system, or even some dermatophytosis. So then maybe these are not really health patients. They have some kind of disorder that previously were not known. But this is, of course, is under continuous study to understand more what is going on with all these diseases. The antifungal susceptibility for this, again, as you can see here, itaconazole, borico, posaconazole, or isavuconazole shown to be active, whereas echinocandins not, fluconazole not, and amphotericin is not the best drug. And also, terbinafine was shown to be active for this agent of chromoblastomycosis. And for the treatment, there are not standard treatment, but there are recommendations. So we don't have evidence, A1, for example, but we have recommendation. Itraconazole and terbinafine and the drugs more used to treat this disease. Other alternatives can be borico or posaconazole, drug combinations in some cases, and surgery also, if possible, when the lesions are small, helps to treat the disease together with the antifungal therapy. Again, I like to show you the differential diagnosis with pictures. That is better. Look. This was the case I show you of chromoblastomycosis. But as you see, compared with this, and this was not chromoblastomycosis, was a kind of a carcinoma. Lupus can have or mimics somehow also this disease. Leishmaniasis, another one. Verrucous tuberculosis, another one. Keratoacanthoma, another one. Coccidioidomycosis. One can say, what is the relation with chromo and cocci? No relation, but the lesions can mimic and be the same, clinically be the same. Sarcoidosis, even psoriasis in different presentations, cutaneous granuloma, or even sporaticosis. So you see that not always fungal infection is present. So we have all in the other way. Sometimes happen that, for example, it can be a tumor and then it's a fungal infection. So this kind of thing have to keep you in mind. So last is paracoccidioidomycosis. Paracoccidioidomycosis, yes, is from South America, not in other part of the world. So mostly, again, in Brazil. But also we have in the north of Argentina. If you see, can be any of the ones that I showed before or not. Also, paracoccidioidomycosis can be confused with other diseases. You have mucocutaneous, or not mucocutaneous, oral cutaneous involvement. This is also thrombiform lip is called. It's also typical for paracoccidioidomycosis. Here, the lymph nodes that are swollen is also another presentation. And then we are going to see and distinguish, because the CT scan can be more or less the same as is presented in other diseases. So, again, it's a dimorphic fungi, as I showed you before, like histoplasma, like blastomyces, like coccidioides, or are dimorphic fungi. The most located places in South America are Brazil, Paraguay, north of Argentina. But at the beginning, it was thinking that Paracoccidioides brasiliensis was the only species in bulb that caused this disease. But after, with the molecular tools, the distribution changed. So Paracoccidioides brasiliensis sensu stricto is restricted to these countries, so Brazil, Bolivia, Argentina, Paraguay here, yes. We don't know why Chile has not, maybe the mountains say, no, you don't have to come here, because even they don't have cocci, more or less, so I don't know exactly what is going on. And then we have Paracoccidioides americana, the same regions in bulb, but it's less frequent. Paracoccidioides lutzi, that is in the Midwest part of Brazil. And in Colombia, Paracoccidiosis restrepoana, and in Venezuela, Paracoccidioides venezuelensis. More or less, they produce the same thing. It's not the same as happened with the sporotis, that each of the species varies a bit in the, what they are doing. So the presentation, the clinical presentations, when you get infected, you can be asymptomatic, yes? But the latency can last a lot of years. This is something to take into account that we can discuss after. Then, what are the presentations? We have the acute or subacute that is usually found in young people And the presentation is with the, as I showed before, the swollen lymph node normally. And you can have the chronic form in which the presentation is more related to find this thrombiform lip or some lesions in the oral mucosa, for example. Yeah. And the problem, and for the chronic form, the association with alcoholism or smokers, these are also have also been described. So they are more susceptible to develop the disease than those that are not smokers, for example. The problem is the sequelae that have sometimes fibrosis that are really difficult to manage for the patients. So diagnosis. This is the disease in which not many tools are developed. So we have to use our eyes to really make the diagnosis. There are some things, but the real gold standard is still to see the yeast from the specimen that you take. So we do the gold standard microscopical examination. Yes. What do we see? This famous sheep whale. So this is the mother cell with the budding cells around. Or if you see just this part, the famous Mickey Mouse. No, it's famous, yes. However, in the real world, it happens and Mickey Mouse doesn't want to appear. So make our life difficult because Mickey Mouse is not there. So he doesn't want to come. He wants to stay in Orlando, not come to, to there. So, and this is from a patient in my hospital. You see that here there is not any Mickey Mouse, and this was paracoxy as well. So you have to see the size of the yeast, the thick wall that they have, and other consideration. And always you have to compare what is going on with the clinics and with the background of the patient. So in culture, 28 at 37 because it's diamorphic. At 28, we can have this hyaline hyphae that nothing really characteristic to say. And at 37, the yeast, mother yeast with buddings that you have to distinguish with blastomyces from here. Because when they are not Mickey Mouse or blastomyces, and sometimes the size is more or less the same, but blastomyces have a wider budding cells compared with paracoxy. That is something to look at the microscope. Serology also by immunodiffusion, in which you place the antigen and then the serum from the patient, and if there are antibodies, they find each other there and form a band, and you can make a titration of this serum. So the immunological diagnosis then are related to immunodiffusion with a sensitivity of 80 to 95%. ELISA or latex agglutination also they were performed. All these tests are more done in some labs in Brazil because they have really a lot of cases. Also by immunoblotting technique, these two antigens, GP70 and GP43, were obtaining, and from that, they saw that the reaction with serum of patients suffering from paracoccidioidomycosis due to paracocci brasiliensis were 100%, whereas from paracoccidioides luci was less sensitive. Antibody detection, sometimes by immunodiffusion, Sometimes it's not 100% because, for example, immunocompromised maybe patients, and sometimes they don't produce enough antibodies to get the reaction positive. Other by molecular detection, yes, the PCRs or LAMP, other these molecular tools directly from the specimen were studied in some centers, but not distributed everywhere. But what is useful is to use molecular tools for identification more than for diagnosis up to date. And also there are more in-house PCRs, and the database are under construction. Again, the differential diagnosis. As you can see here, for example, paracoccidioidomycosis can be confused with other endemic mycosis like histoplasmosis or others, or with tuberculosis. This, I told you that you have lesions in the oral mucosa, but histoplasma also can do when it's in the chronic form normally. Also, you have pneumoconiosis or sarcoidosis. The treatment, again, is itraconazole, because I told you it's not very difficult to treat when it's not really in immunocompromised, for example. With itraconazole, is responding normally quite okay, but also trimethoprim is another drug that is used in cases that itraconazole cannot be used. Amphotericin B, if it's needed, can also be given. And the criteria of cure is remission of the lesions, negative mycological examination from the secretions, regression of radiological imaging, negative serology, and good therapeutic response. The problem is, as I told you, intense fibrosis, as you can see, for example, here. So this patient have a lesion in the face, but then it retracts. So always they have to be advised that despite therapy, it can happen, the fibrosis. Or when it's pulmonary, then they have very short breathness. So sometimes the response to antifungal is good, but then the sequels are not good. So with this, I finished my presentation, but I wanted to show you my hospital. That is my hospital. So you are welcome to visit me anytime when you go to Argentina. This is my group, so more close in mycology and my team in the hospital, hematological, physician, etc., from clinics and so on, because we do the wrong patients, so every day. And last but not least, but I want to show you my two mentors. That was Dr. Sibren de Hu, that I did the course with him during the course of medical mycology for 20 years already. He was my promoter in my PhD, and we did, I'm co-author of the Atlas together with him and other persons. And Dr. Thomas Walsh, that is from here. I don't know if some of you know. He's a very known physician, and he also guides me, and I know him for 30 years already. He said, when you were a kid. So, well, this was that. So thank you so much for